政府人員入嚟，唔該。
Let's invite the administration team to join us, please.
都係 lead member 第一次啫，俾阿 Alan 都係15分鐘，然之後好似上次咁每人10分鐘。
冇所謂，我係睇到時間都上一堂啲時間都 OK 嘅啦。睇我哋係咪有嘢要話聲先？
都係講呢啲 intro， 即係介紹嗰啲官員啫。
官員唔使介紹咯。唔
使就可以直接 lead member 開始。
好啊。早晨啊 ，Dr. Go。
Good morning, Dr. Ko.
Good
morning, everyone. Dr. Ko and your team, I don't think I need to introduce you. So please go direct into Chapter 3. Yes, Alan, can you have a go first? So please refer to the relevant paragraph so the witness will be able to find them more easily. All right, thank you, Chairman. Well, during the last hearing, we saw that very clearly that under Cap 165, that's the hospital nursing registration. Yes, in year 2000 there was a review. But then subsequently there was no further follow-up action, and according to the Bureau Director, it's not that they did not do anything about it at all, because there was this code of practice. But then for the code of practice to be effective, as we can see, we would have to rely on the inspection and also the Sentinel incidents reporting system, and also the monitoring of complaints in order to supervise or monitor the work of the hospitals or the private hospitals of safeguarding public interest and health. So today we are on the monitoring of Sentinel events and complaints. At the outset, I'd just like to ask this. In paragraph 3.3, the audit said that if the system is a voluntary one, relying on the voluntary reporting by the private hospitals, then there might be underreporting. And if you can look at 3.3, here they refer to what the DH said, and it's about the setting up of this surveillance system. And in setting this up, the DH did make reference to the criteria or guidelines issued by the World Health Organization, i.e. successful Sentinel reporting or event reporting system should be non-punitive and confidential and lead to constructive responses. And in paragraph 3.7 or 3.17, in 3.17 we can also see that mention was also made about the fact that from 2007 to 2011, the DH only issued 3 press releases relating to Sentinel events in private hospitals. Also, the DH would upload an aggregated figure of Sentinel events onto its website on a quarterly basis. However, identities of the private hospitals concerned and details of the Sentinel events other than the category they fall into are not disclosed. In fact, in Part 6, mention was also made about the issue of confidentiality. should we review that? Chairman, I'd like to put this to the Secretary. Well, the WHO referred to a voluntary and confidential system. But then should it be done at a particular stage, or is it that from beginning to end it should be kept confidential? And to whom should it be kept confidential? Does it mean that you must not disclose it to the public? Because when compared to public hospitals, this is a very different approach. So I'd like the Secretary to elaborate on that. Secretary, Chairman. As the department explained in para 3.3 about the reporting system, and there are 4 functions under the system. As you can see, 3.3 A, B, C, D, and the main purpose is to learn lessons. In other words, we will have to identify the real reason. If we can get to the root of the problem, then we'll be able to change the organization systems and procedures in order to reduce the probability of occurrence of such an event in the future. I believe that in coming up with such a system, the WHO did consider some factors, and the whole purpose is to improve the services or service delivery. But then, of course, what we are talking about is another area. That is about disclosure to the public. And the main reason for disclosing the details to the public is that, well, if there are matters involving public interest, then the public should be able to know. So it's slightly different. So on the issue of confidentiality, I suspect that well, when you ask the frontline staff of hospitals to report certain events to you, well, by making it confidential, then we're just trying to make sure that whoever is doing the reporting, he will not have his identity disclosed to everybody else, and that would also dampen his desire to report. And of course, we will also have to make sure that if patients have not given any consent, then we will also have to protect the patient's privacy. So I suspect that's the reason. I don't know if the director would like to add. Director? Well, we have to refer to the guidelines, and the guidelines talk about confidentiality and also the reporting system. And with regard to the person making the report and the institution, they should not be punished. And also with regard to the patients and also the institution, should their identities be kept confidential, because the WHO feels that if there is no confidentiality, then that would dampen the desire, and the effectiveness of the system will be adversely affected. But of course, I understand that members are very concerned about the criteria. In fact, at the Health Services Panel of this Council on the 11th of May 2010, we already submitted papers pointing out that in disclosing such incidents to the public, the DFH would put in place these arrangements, and the announcement would be made immediately. Number 1, if there are serious impacts on public health. Number 2, if there might be sustained risk to public health, and immediate action will have to be taken in order to prevent any occurrence of the events again. So as you can see, on 3 occasions, press releases were issued by the DFH, and that's because they came under those categories that I just referred to, and we already provided papers to the HSP to explain this. So are you referring to para 3.5? So with regard to the reported cases, is it what you said in para 3.5? That is since January 2010. Well, it's about the list of events introduced in 2007, but then there was some discrepancy between the HA and the DFH, and then after making reference to the practice of the HA in 2007, we tried to standardize this, so that's what 3.5 is about. But then Mr. Leung was asking about the WHO's guidelines, and I was supplementing that in Hong Kong, in issuing press releases, there would also be certain criteria and guidelines. Yes, I was asking if you were referring to 3.5. Was that also what you referred to in answering his question? Apparently that's not the case. So can you clarify that? Well, Chairman, can I clarify on this? Well, just now the DH or the director said that for public hospitals, on what occasion would they be reporting the case to the public? When there is a serious impact or when there is a patient death, then that's for public hospitals. But then for private hospital, as the director just said, only when the incident might pose serious impact on the public health system would the incident be disclosed. So I'd like to know why the distinction. And number two, with regard to the serious public health impact, what does that mean? So what kind of incidents are you referring to? Director? For serious public health implications, well, if it's a systemic problem, for example, if it's wrong dispensary or dispensing of drugs, but then if we find that they might not have done so for just one patient, many patients might have been affected, and then we would view that as an incident with serious public health implications. And number two is the contamination of medical or healthcare apparatus. For example, after a surgical operation, if there is infection on the patient, and if we trace that and we found that well, there might be other patients who might have used the same operating theater or the same apparatus, then we will have to disclose it. For public hospitals, they will disclose the incidents on their own volition, but then they would just be disclosing the incident itself. And according to my understanding, in making the disclosure, they would also well, it doesn't necessarily mean that they would be disclosing the details of the hospital in question and also the individuals in question. So that's what we have been doing, and we are trying to standardize that. And as I said, at the HSP meeting held on the 11th of May 2010, well, at the same meeting, we also said that for the hospital in question, it would be responsible for disclosing the details where there was some serious incident taking place. If there is no serious public health implication, then we would rely on the hospital itself to make the closure. Mr. Leung, well, last time at the hearing, the secretary speaking on behalf of the administration that they would be spending a year to conduct a review. But then, if I understood it correctly, please correct me. Well, according to the secretary, apparently he was saying that, well, for public hospitals and private hospitals, all right, after a sentinel event has been reported, then when will the administration be disclosing the details? In fact, that would also be part of the review. So I'd like to ask the secretary, well, in conducting the review, will you be trying to standardize the approach adopted by public and private hospitals in reporting sentinel events? So would you be moving in that direction? Bureau Director, yes, indeed, that's the direction that we are taking. So within this year, you'll be coming up with a report. Yes, in a year's time, we'll be coming up with a report, and of course, many areas will be covered. But of course, as Mr. Leung just said, in terms of making disclosure to the public about sentinel events, we will try to move in the direction that was just said. Can I ask another question? Well, for different private hospitals, as to when they report the cases and how they report the cases, I understand that there is no standardized approach. So will the Bureau be looking into this so that there will be a standardized approach adopted by different private hospitals in reporting sentinel events, so that the whole mechanism can be revamped? Bureau Director, yes, that's correct. In other words, for different private hospitals, they should adopt the same criteria in reporting such events. Other members? Yes, Mr. Paul Chair. And then next, Mr. Leung Sing. Chairman, looking at para 3.5, it says that since January 2010, the DH has revised the list of reportable sentinel events, and as a result, some of the figures might have been very different from what they used to be. Well, as you can see, in 2007 to 2009, every year there was 35 to 39 cases, but then since 2010, there were only 8 to 5 cases. In other words, there was a very substantial change, and in a note, it says that because of the revision of the list of reportable sentinel events, some cases or some categories have been taken out, and as a result, there was a difference in the figures. Alright, I'd like to know that as a result of this revision, between public and private hospitals, in terms of the discrepancy between the reported cases, has it been narrowed, or is it almost the same, or is it that you still need to revamp them so that there can be a better alignment, and then for both public and private hospitals there would be a more standardized approach that would be readily understood by the public? Dr. Koh, I think what Mr. Chair said was correct. Well, between the public and private hospitals, I think the reporting system is now getting closer, so the gap has been narrowed. Alright, you also talk about the WHO guidelines, and the WHO advocates that a confidential and non-punitive system be set up in order to result in more constructive responses. So, by adopting this approach, are we looking at the sentinel events, or are we talking about medical blunders, or would that apply to both? Secretary. My understanding is that for sentinel events and medical blunders, I think we are talking about two concepts, and sometimes there is a need for us to distinguish between the two. Very often, for outsiders, they might think that this is a sentinel event. But then, if you look at the event independently, we will have to have the experts doing the evaluation before it can be decided whether or not it's a medical blunder. Alright, for certain sentinel events, well, if there might be new discovery, or according to some old approach is found to be not desirable. For example, if there might be new diseases and there is a need for the procedures to be further revised in order to prevent this from happening again, then there might be an urgent need for some action to be taken in order to protect public health. But then if it's just isolated cases involving some mistakes or blunders, then I do not see why we have to use some non-punitive or confidential approach in doing the reporting. So I'd like the Bureau Director to let us know, do you think there is a difference? Well, it's not about your personal view, Bureau Director, because during the conducting of the audit by the auditor, well, we are looking at a report. We are not looking at your personal comment as to how things should be changed in the future. Well, it's up to you to decide in the future. But then what's your view on the report? Yes, in response to the question raised by Mr. Chair, well, where there are incidents which the public might think that they are sentinel events, I'm sure you will understand it's not about my personal view. Well, for each and every one of those, we will have to have the experts conducting the investigation before we can determine if any blunders have been committed. But of course, depending on the degree of severity, well, in some cases it might be a wrong dispensing of drugs, and sometimes it might be the wrong transfusion of blood. Then of course, obviously that there must have been blunders, but then where did it take place? But then, for death after surgery, it might have been the result of complications and so on. So we will have to conduct investigation before we will be able to tell. Chairman, if you look at different industries, well, taking a travel agency as an example, every time when you look at a weekly magazine, there would always be some incidents involving the travel agency, and there might be claims of damages. There might also be operational practices that might have been criticized and so on. But then of course in such events it might involve patients' privacy, and we will have to be very careful about this. But then for private hospitals, because their services are actually facing the public. So it's a matter of consumer interest that we're talking about. So in the past, when you deal with such issues, maybe you might have attached too much importance to the hospital or the patient's reputation, and as a result, the public might not have been able to have access to such information. So is it something that has been happening all the time, and as a result, private hospitals might be committing a lot of mistakes as a result of that?
Secretary, I think at the opening address, I already said that we would accept the audit recommendation in 3.21, and that is we should consider disclosing the sentinel events and the details as soon as possible, and we're heading in this direction. Paul. Now, about the identity of the hospitals concerned will more be disclosed to cater the need for the patient's right to know. Well, for events involving public health implications, we will be disclosing information in this direction, and that is to say the transparency will be enhanced. In para 3.23b, in the past, you do not have this practice of referring cases of sentinel events involving professional misconduct or substandard performance to professional boards and councils. Is it the case that you place emphasis on patients' privacy and reputation of hospitals, and therefore you decided not to refer to such cases? And Secretary, as I said in the opening address, for cases of sentinel events involving professional misconduct or substandard performance of significant public health impact, we would consider referring the cases to professional boards and councils for investigation and follow-up. Then, Secretary, is it the case for public hospitals as well at present? Just now, Mr. Eleanor asked you about the alignment of the private hospitals' practices with public hospitals. That during the investigation stage, if it's revealed that the sentinel events involved professional misconduct or substandard performance, then this is the approach that we're going to take. So when was the change implemented? Since when was the new approach taken? Secretary, in response to audit recommendations, and like what I said in the opening address, we already stated our position. But of course, now, we do not need to wait for the review to be completed. We're already taking this stance. Chairman, my question is, when was the change implemented? I cannot tell an exact date, so it has been implemented already. If you ask us our current attitude, then that is the case. Then so far, has any such cases been referred? I need to defer this question to Director and see if she has the figures. Now let me supplement the answer on our practice. Now, on cases of sentinel events reported, we will launch an investigation to understand the case involved, and letters will be sent from the hospital to the patient and the families of the patients, telling them that the DH has already started an investigation into this case, and if necessary we can be contacted. And when the patient contacts the DH, the patient will be told what the DH will do, and if the case involves a professional misconduct of a medical staff, the patient has a channel for the case to be referred to the relevant professional boards. We will provide this information to help the patients. But the member is asking how many cases has been referred to the professional boards. Can you answer this question? I don't have the figures. Please supplement the figures if you have the figures. I don't have the figures, but in fact, in the earlier part of this year, we received a case of private medical practitioners. Well, not exactly a private hospital, but a private Chinese medicine practitioner using steroid in his Chinese medicine prescription, and the case was referred to the Chinese Medical Practitioners Board. And that I want to explain that this is the approach we will take if necessary. So for hospitals, no case has ever been referred to under the new system. This is the existing practice, but I do not have the figures for cases of cases referred to the Medical Council over the past 3 years, but this is the existing practice. I hope it's not the case that we actively refer cases of Chinese medical practitioners, but not Western medical practitioners, because it seems we're offering better protection for them. I'd like to know whether no case has ever been referred to and there is no such practice at all. When a judge, in the course of adjudicating a case, finds that there is a professional misconduct on the part of the lawyer, the judge will not direct the client to file a complaint. The whole case file will be referred to the Bar Association or the Law Society for follow-up. So is it your existing practice that you only inform the patient of his right to do so? If it is the case, there is no need for you to do so. The information is available online. Secretary, I'd like to clarify one point about Mr. Chair's remarks. Well, this is not the practice that we're adopting. If the sentinel events may involve professional misconduct, and we know that at the beginning of the investigation, we will not ask a patient to refer the case. But at the initial stage of the investigation, if we have not yet known of any professional misconduct involved, then we would go on with the investigation first. Well, the second part of the question, it has to do with different approaches to different professions. Earlier on, there were high-profile cases in the community, and we already said that on conclusion of the court proceedings, the case would be referred to the relevant professional boards. But how over the past 3 years, how many cases have you actively referred to the boards and councils? I don't have the figures. Perhaps let director go back and find out about the figures. But I want to emphasize this point. Whether there are any such cases depend on whether such cases have been discovered of being involving professional misconduct. If there were such cases, of course, we would have the figures. If there were not, there were no such cases, then of course there won't be any such cases. Now, the problem is if you discover professional misconduct in these cases, you should refer these cases to boards and councils for follow-up action. It has to do with the follow-up and investigation work. Secretary, in fact, you are repeating what Mr. Chair said. You are being asked over the past 3 years, as you're the new secretary, so over the past 3 years, or over the past few months, or over the past 18 months, according to your record, whether there are any such cases, can you answer this question? Now, just to respond to the last point, of course, if we have suspicions, we will, or if we have doubts, we will refer such cases. But we may not even have cases. But what if there are medical equipment left in the abdomen of patients? And aren't they clear? Yes, but not all cases are that clear. I'm sorry, I've spoken beyond the time limit. Anything to supplement, Secretary? Paul, you may continue. Director, you want to supplement? I want to provide a piece of information for reference. Apart from the Sentinel events reporting mechanism, according to the Coroner's Court Ordinance, there is a list of reportable deaths. For example, if the death is a result of the use of anesthetics or the death happened after 24 hours of the application of anesthetics or 48 hours after a major operation, then according to the ordinance, these are reportable events. After the case has been referred to the coroners, an in-depth and systematic investigation will be carried out. But Mr. Chair, is not only about cases involving death. There might be serious injuries or cases with impact on patients. Any such information? Well, one final question for this part. Will you consider in the future all suspected cases of medical blunders would be referred to the professional boards and councils? And will there be an objective checklist available? And so that the professional boards and councils can conduct their own investigation, and in turn the administration's resources can be saved. Secretary, for cases involving professional misconduct, as per the audit recommendation, for cases of exceptional events involving professional misconduct, these should be referred to professional bodies for investigation, and we have accepted this recommendation. Mr. Ng Sing, still on the same paragraph, 3.12, regulatory actions on sentinel events. In February 2010, there was an ICAC assignment study. Now, here it says the DH has never rejected the registration or re-registration of any private hospitals. Now, there were serious cases or cases of sentinel events mentioned, but in the end, there was no impact on the registration or re-registration of private hospitals. Nor had the DH prosecuted any party under the ordinance. So, despite the happenings of sentinel events on a continuous basis, there had never been such a situation. So is it the case that in the past, the ordinance had never been invoked so as to issue any warning? Has it to do with the shortcomings of the mechanism? So that there is no link between the ordinance and the cases, and therefore there is inadequate investigation work. And has anything been done by the ICAC? I'd like to seek evidence in this regard. As far as past cases were concerned, was it the case like I mentioned? Secretary, Mr. Ng asked whether there were any cases of refusal of registration or re-registration of private hospitals. For cases as serious as something like this, it never happened before. As for other cases, as mentioned, we have already agreed that in the future we will issue warnings at different levels so as to reflect the severity of different events. For example, whether it should be an advisory or warning letter or letter of reprimand, we will consider all these under the new system. So it's not the case that under B, the study identified that one of the major shortfalls in the system was that in relation to the relevant breaches, the offences and sanctions provided were grossly inadequate to deter attempts to breach the conditions. And you should resort to refusal to registration or re-registration. So my question is, there is an ultimate solution from the final regulatory body that the private hospitals would be allowed or disallowed to re-register with the DH, or was there any justifications in making a decision that there was no need to refuse registration? And whether the matter should be escalated to a certain level so as to impose a sanction in order to achieve a deterrence effect. Secretary, just let me make a response. Director may supplement my answer. DH, as the enforcement unit, has been made available this system with the most serious sanctioning action. Of course, the DH can refuse registration or re-registration of private hospitals, but in the past we had never encountered cases where we had to refuse registration or re-registration. We agree with the major shortfalls as pointed out by members. In terms of the regulatory regime, at present, there is a lack of different levels of warnings to reflect the different degree of severity of cases. Director, I can supplement that in the past cases where we investigated into sentinel events, there was no case serious enough to warrant a refusal to registration or re-registration. So can I take it that for all cases in the past, none of them warranted the ordinance being revoked to impose sanctions on them? And that is to say, for 3.12 para B, the last sentence says, the issue of advisory or warning letters had little impact on private hospitals. That is to say, for sentinel events happened in the past, they were not severe enough to warrant a revocation of the license or refusal to re-register the private hospitals. So none of the cases you mentioned reached this degree of severity. Correct, Secretary? Right, I think Director and I make it clear that for complaints and events that we investigated in the past, none of the cases involve the most severe type of sanctions, that is a revocation of the license or refusal to re-registration. However, we have also expressed that in reviewing the mechanism, we're going to issue different levels of warnings or sanctions to reflect the degree of severity of the cases, so as to make up for this shortfall. That is, you're saying that you're going to improve 3.12b, and can you tell us, for 3.12b, how or when are you going to implement changes to improve the existing system? Chairman, in the current review, some things might be outside the scope of this ordinance, but for example, for things like advisory or warning letters, we can implement the change, whereas different levels of reprimand or sanctions, or whether fines can be imposed, I think these can only be done through legislative amendments. Mr. Ng, thank you. For 3.13b, I think according to Secretary, in the future, for cases involving professional misconduct of doctors or nurses, they will be referred to the boards and councils for investigation before reaching a conclusion.
So there can be a mechanism to handle the cases, and I think that you will look forward and plan ahead on what to do. Secretary, yeah, Mr. Ng was referring to 3.13b. Yes, the DH, as an enforcement agency, should be serious with each case reported and carry out investigation before making any decision. For any case that pose risk to public health and cases that involve professionalism or conduct of doctors, in cases of sentinel events, the DH would, as we said, refer the cases directly to regulatory bodies for the field. Mr. Ng, yes, if you have strengthened your investigations in the future, I believe that the director or secretary would, on the basis of your investigations, in cases of potential problems with the systems within the private hospital systems, I'm sure the Bureau would actually, in cases of central events, after investigation, make a decision on sanctions related to registration or licensing. Secretary, yes, I can't say that certain events could lead to the most serious sanctions. But on the whole, I think you're right to say that once we find that there are cases that pose major hazards to public health and any cases that amount to serious negligence of professionalism, and if those cases reflect the problems in the system or management of private hospitals, then of course we would take follow-up action. Apart from problems with individual officers, if it turns out that the problems reflect problems with administration in a hospital, of course we would target at the misadministration and adopt warning or sanction, or depending on the level of seriousness. Yeah, just then there are actually the mention of the mechanisms of reporting of sentinel events. So I'd like to ask you, the Director of Health said you would provide or take actions as soon as possible. But I'd like to ask you, if we can't uniform the series of actions to be taken, what are the potential obstacles to providing uniform actions, and whether taking uniform actions would have any effect on cost effectiveness? And also, if you are to uniform the taking of actions, can we have that done within or after a year? Another question is in paragraph 3.23, as we mentioned, about international practices. If we are to have confidentiality and that kind of arrangements, but could that, the non-punitive and confidential arrangements, could that lead to the impression that we are allowing hospitals to actually protect one another? Secretary, I think the Commission's recommendation 3.22, we do agree with that, but it also involves the actual situation, because hospitals do risk management work, and that's a separate issue from sentinel events. Any supplement from the director? Can you tell us the potential difficulties, or would there be any impact on cost effectiveness? Chairman, since 2010, we have aligned the system and practices for disclosing sentinel events. As for your second question on WHO's criteria, whether it would lead to hospitals protecting one another, I think WHO criteria are imposed for the sake of patient safety. And so the goal is to ensure patient safety. So WHO came up with suggestions to encourage medical staff to report events with the purpose of making improvements and avoiding the same events from happening again. In cases of professional malpractice, actually that do not contradict the goal, because the professional regulatory bodies can handle the cases, so there's no conflict involved. Alan Liang. Thank you, Chairman. I'd just like to have it clear on record. As for whether the DH would directly refer cases to the Medical Council or Nursing Council, in paragraph 3.15, it mentions that in June and August 2010, the DH then, not the present director, but the DH then cited the concern for privacy, saying that the referral of cases might impinge on patient privacy. But since the beginning of this inquiry, I've heard that the director say that this will no longer be used as a reason. So when they come across cases of medical events, if the DH feels that the professionals involved, whether they be nurses or doctors, had committed negligence or improper conduct or provision of services below standard of professionalism, then the cases would be referred. But is my understanding correct? First of all, Secretary, yes, let me reiterate that in cases that involve negligence of medical professionals, for central events, we would make direct referrals. As for Mr. Liang's point about privacy, as I said, it's not that we will not consider privacy, but we would consult patient and ask for their permission first. Okay, thank you. Thank you for your clarification. I just want to make it clear on record. And just then, Chair YUEN asked about when you would cease not referring cases on the basis of patient privacy and implement the new mechanism. Because the previous director back in 2010, June and August, used the excuse of privacy. So well, we haven't got an answer to Cher's question yet. That is, from when will we be freed from this excuse? And since we were freed from that, or that excuse was no longer used, how many cases of referral have there been? So, can you let us know whether you would provide us with a figure after today's meeting? Okay, Secretary or Director, I think we've agreed earlier to look at the data. Director, yeah, let me supplement. As for patients' privacy, it is still an important factor. because before making cases to MCHK or NCHK, we do need to get the patient's approval. Because we need the patients to provide first-hand information, and the patients will need to be present at public hearings of the regulatory bodies as witnesses. So therefore, we need patients' consent, no matter what. Of course, I understand that. But I think the director and the secretary agree that both of you present agree that you would no longer use the response given by the previous Director of Health to the ICC, as mentioned in that paragraph 3.15a. So that attitude is now changed, right? Yes, is the attitude changed? Chairman, we will not make an across-the-board statement that we will not refer cases on the basis of that reason. Yeah, so if we put on record, can we put on record when was that attitude changed? Can we have a date? Secretary, I think you've answered, right? Secretary, can you answer Mr. Leong's question again so we can put it on record? Chairman, in answering Mr. Chair's question, I said that I could not give him a date because you need to refer to a case first. But our attitude is as what we've said, and the Director of Health also supplemented that. We abide by the principle. As for your follow-up questions on whether there have been direct referral of cases in the past few years, we don't have the figure offhand, but we've promised to check our records and see what data we have. Okay, yeah, let me ask another question. I just want to ask about the issue of confidentiality. To me, it seems that confidentiality has been used by the authorities as a protective shield, a reason for not disclosing hospitals involved in medical events, or keeps hospitals from revealing their names. So WHO is there to protect patients' welfare. So say if you are investigating a case and you need to keep the name of the hospital confidential, but after your investigation is over, and once the case is confirmed, should it not impinge on patient privacy? For example, disclosing the kind of illness the patient had. So under that circumstance, is that at that stage you would not need to keep information confidential? Is it a matter of at what stage of investigation you are in, and also whose privacy are we talking about here? They need to be protected. Secretary, can you answer it from a policy perspective? Chairman, I'd just like to clarify the meaning of confidentiality. I think no matter how we enforce the law, actually it's up to hospitals, and particularly frontline staff in the hospitals, to make a report. My understanding is that the WHO criteria is that people can be encouraged to report events. For example, frontline staff, once they have seen what happened next door, then they can come forward and make a report. We feel that if the confidentiality clause is in, then people can be encouraged to come forward. Okay, so if that's your concern, then should a case be confirmed, then it shouldn't be a problem disclosing the name of the hospital, right? Yeah, Secretary, I think I think as for whether the incident should be reviewed or disclosed to the public, it depends on the seriousness of the case and also how much effect the case has on the public. If it's a case with warning effect, then we need to disclose it. Secretary, we just heard that we also mentioned about the aligning of public and private systems when it comes to reporting of events. So, in fact, we have similar criteria now for both systems. In order to, for the purpose of clear records, can the Secretary tell us the two sets of what are similar guidelines? Are there any differences that need to be dealt with so that we have an aligned system? Director? I think the HA, HA is in charge of its own organization, so in case of major sentinel events, it's HA that reports the cases. But the Department of Health does not operate each individual hospital. That's why, as we said earlier, we will make disclosures on three conditions. Under three conditions. But for other cases, we would ask the person in charge of the hospital to respond on their own to media inquiries or individual requests. So it's up to the organization operating the hospital to report events. For DH, we only report sentinel events or make disclosure about sentinel events. And for hospitals with sentinel events in the future, we will look into what more we can do. But I hope you can understand that with sentinel events, sometimes it's not that problem exists within a hospital. Back in 2009, out of the 52 events then, 34 involved patients' own cases, and 9 were actually 9 cases came in the wake of operations that patients had, or there were complications. So, if the information led to public misunderstanding, then that may not be the fairest way. But we promise that we would look into how to align the systems and practices, and also how to disclose the outcome of investigations at an appropriate time. I think from the director's answers, I've got 2 more questions. Well, we're talking about 2 alignments. One is the alignment between private and public hospitals, and the director said that they would try to ensure that there is the alignment between private hospitals and also alignment between private and public hospitals. Let me ask about the first alignment, that is among private hospitals. And the directors or the secretary said that we need not wait till the 1-year review is over and they are ready to issue guidelines. So does the secretary have any idea in mind already about how to align the practices and systems among private hospitals? And what is your timetable? Secretary? Do you agree with what Mr. Liang said? And what are you going to do? I'm not quite sure what you asked. Do you agree what Mr. Liang said, for example, the alignment between private hospitals? Yes, of course. Yes, of course, I agree. And then how about the second part of his question? Yes. Under the steering committee, there is a working group which will look at the regulatory framework for private hospitals, including the way to deal with complaints and sentinel events and the mechanisms for disclosures. And then we would discuss it with the HA and try to come up with an alignment. If you ask me a day, I can't give you really an idea on the timetable. I'm talking about alignment among private hospitals. So let me clarify the question first. I was asking about alignment among private hospitals. That is 3.19, paragraph 3.19 in the report. So you want to uniform the operations of private hospitals. As I just said, that different hospitals have different bosses and there would be different mechanisms. And just then the chairman sought from the secretary an answer on whether you agree with what I said.
So you're trying to align the two systems. You do have the power to do so, right? Policy secretary, so you can issue guidelines so that among private hospitals there would no longer be any difference. So in exercising such powers, well, you do have the powers in your hands. So I'd like to know how are you going to exercise those powers and what is the timetable for exercising those powers? All right, now I'm clearer about the question. Well, if that is the case, there is no issue or no question of issuing a new set of guidelines at all because, well, in issuing guidelines by the DFH, they should always be consistent. So there is no question of the DH issuing different set of guidelines to different hospitals. So we would just be issuing a set of guidelines applicable to all private hospitals. In the past, I suspect that with regard to the reporting system and the circumstances or the details that might have been submitted might be different. There is no question of having different sets of guidelines for different private hospitals because, if it's about certain complications in the wake of certain surgical operations, well, before 2010, well, for different private hospitals, they might have done so differently. So they some might be more positive about making the report, others less positive, and therefore we do have some complications that are rather common after certain surgical operations, and if they are classified properly, and once they are classified or they are not classified as sentinel events, your focus might have been placed on the fact that the figures might have dropped. But then there is no question of being inconsistent. It's not about our guidelines that are not consistent. It's about the individual private hospitals' response. Before 2010, different hospitals might have responded differently to the system, and therefore some might be more positive, others less. But then under the set of guidelines, have you given that guideline? Well, you said that you had a set of guidelines, but then how did you give it to the hospitals, and how would you expect them to implement that? Well, yes, I understand that. Well, I'll be deferring to the director who will give you more details. But then, according to what Mr. Leung just asked, apparently we have not issued a consistent set of guidelines to the private hospitals. But then, in issuing the guidelines to the hospitals by the DFH, the guidelines are consistent. But then, different hospitals might have responded differently to the guidelines. So it's not the set of guidelines that is not consistent. It's the response from the hospitals that has been different. But then, if I can refer you to 3.19, that's the report. I think that might be clearer, and the director can also assist the bureau director. As you can see, LegCo members also noted that under the Sentinel reporting or Sentinel event reporting system, private hospitals are required to develop their own policies and mechanisms to manage Sentinel events. So what's important is that they have to come up with their own policies and mechanisms. So I'm targeting at this word. So would you be exercising your powers to ensure that in doing so, instead of coming up with their own policies and mechanisms, they will be able to subsume under the set of guidelines issued by you? So that's my question. Director or Bureau Director? Well, I'll ask the Director to speak first, and then I'll see if I need to supplement. Well, for private hospitals, policies and mechanisms in dealing with sentinel events, well, in a set of guidelines, we require each hospital to come up with a system, including those who would be responsible for conducting the investigation. And also, there should also be a mechanism to respond to the complainants' complaints, how much time and what procedures are in place. So that mechanism is required. And you might wish to know the details of the mechanisms, and you want them to disclose them. Well, under the current set of guidelines, which was disclosed or discussed at the HSP meeting held on the 11th of May 2010, I said that there was a mechanism adopted by the DFH, but then for sentinel events, meeting the requirements or the criteria, then they will have to disclose to the public. For example, for any unexpected death and also for any reportable cases resulting in or unexpected diseases, they will have to report. So this is the existing mechanism. I understand that Mr. Leung would like to know if there might be more detailed mechanisms in place. I'll talk to the private hospitals to see how those can be aligned. In fact, with regard to the steering committee, well, the fourth committee will be looking into it, because precisely the terms of reference for that subcommittee would be looking at how private hospitals should be regulated, and within this group, it will be looking into this. And in response to members' concerns, I will be talking to the private hospitals to see what can be done to further improve the guidelines. Well, the Bureau Director said that we didn't have to wait for a year before the report is out. You might be able to do it before then. Yes, we don't have to wait until after the report is out. So, as I said, there's a working group, and the working group can look into it right away. So, will you be doing it right away? So, have you got a set of guidelines? Can you give us a copy of that set of guidelines? So that would already solve the problem. So we'd like to know what sort of guidelines have you given to the private hospitals. Mr. Leung, Chairman, I think you're right in the sense that we are concerned about the situation with regard to different private hospitals. We want them to adopt the same approach. What we are concerned about is, at present, you have already got a set of guidelines, and you have already imposed some requirements, but then the objective effect is that different hospitals might be interpreting that differently. That's why we believe that we will have to align that. We will have to make it consistent. We are also pleased to hear from the Bureau Director that this is your policy direction. That's why I was asking as to the speed of implementing it. Well, I don't think I need to put further pressure on the director. The director said she would be doing it as soon as possible. So let's put on the record, and then we'll see how things are done. But finally, I'd like to ask this final question. Yes, please. That is between public and private sectors. Well, if you look at paragraph 3.18, all you need to do is to look at this paragraph. All right, for public hospitals, as to the timing of the reporting of the Sentinel incident, when there had immediate major impact on the public or involved a patient's death. But then, on the other hand, for private hospitals, the standard has been escalated. In other words, only if such event had major impact on the public healthcare system. So between the public and private healthcare sector, apparently there are some differences. And according to the Bureau Director, this is also the direction that you'll be taking. You're trying to align the system between the public and private sector. So will you be taking immediate action, or do you have to wait for the review to be completed in a year? Do you have to consult again, and so on? As I pointed out last time, because under the current law, under Cap 165, that is about the hospitals, nursing homes, and maternity homes registration ordinance. You do have very extensive powers. Yes, I understand your thinking. That is the best thing is to make it clear in the law, so that there would be very detailed provisions. For example, how much the hospital can be fined, and under what circumstances the license could be revoked. But then, even though at present the provisions are not that detailed, but then it has already given the Bureau Director this power. Of course, he might be concerned that there might be judicial reviews if he exercises those powers. But then the best thing to do might not be making the provisions more detailed. As I pointed out at the last hearing, it's not that he could not do it, it's just that he was not willing to do it. So I'd just like to know that on that premise, that you already have the power under the law, can you allow us to put on record that is between the public and private hospitals in terms of the alignment of the two systems? How are you going to exercise your powers in order to ensure that they will be aligned as soon as possible? Bureau Director, well, as the Director of Health already said that, amongst the private hospitals, the system should be aligned, and the same would apply to both public and private hospitals. We don't have to wait until after the steering committee has completed its work. If we believe that certain parts are already adequately if we believe that certain things can be done before, then we'll be doing that. Mr. Paul Chair, just now I used well, you used a more positive way to describe it. You talk about the response by the individual private hospitals, and some might be more positive, others less. But then if you look at the transcript of our last hearing, page 109, the same question has been asked. Well, you describe some private hospitals to be tamer and also more positive. Well, they might be getting a bit more assistance, but then for the less positive and for hospitals that try to cover up more, well, on the face of it, their records might be clearer and better. So I'd like to follow up on this. Under the existing system and policy, are there any measures that can punish those private hospitals that might have been less positive, but then they might have been found to be doing somewhat worse? Bureau Director, well, I think this happens to the situation when the guidelines that we issue to the private hospitals with regard to sentinel events, we just refer to the complications that might happen in normal operations, and they would also have to require that. But then after narrowing the scope of reportable cases, we believe that the room to maneuver would be narrowed. Bureau Director, are you referring to Table 4, that is about the situation in 2010? Yes. Chairman, I believe the focus of the issue is not the situation after the revision, whether the situation has improved or not. But then my question was very clear. That is, under the existing mechanism, are there any policies or measures to prevent those private hospitals that have not been positive at all? How can you ensure that the system can be fairer to them? Well, I believe that if the guidelines are becoming clearer and clearer, then in the future, when the DH receive the reporting of such cases, when it conducts analysis, you'll be able to see if there might be instances whereby cases which should have been reported under the mechanism, but then they might not have been reported by the private hospital in question. And if that is the case, then with regard to our regulation of private hospitals, we will be able to come up with more detailed sanctions that would allow us to tackle those problems. But then coming back to the issue, that is, at present, if we find that some private hospitals should have reported certain cases to us, well, it's very clear under the guidelines that they should have reported, but then if they fail to do so, then under the law, there are some provisions which might sound a little abstract at present, but then there is still room for us to maneuver. We can always reprimand, admonish, or even issue certain letters or regulatory letters to them. So before we improve the mechanism, these are the things that we can do. Apparently, according to the Bureau Director, he's hoping that in the future he would be able to do this or that, but then at present, they should have done this or that. But then what we are doing here is to collect evidence, and we are trying to know whether or not there is no mechanism available at present to enable you to enforce it more clearly, whether it's by way of issuing warnings and so on. Well, some of them might have deliberately covered up, but then they might have been found out. For example, it's like unauthorized building structures. Well, for those who make the reports in advance, well, we should not be viewing them as the more naughty ones, but then for those who have only been found out without reporting, then they were actually the bad guys, so they should have been disclosed. I do not agree that there is no mechanism in place right now, but then there is room for improvement. But then if the DH found out that this is happening, then actually we can even publicly reprimand the hospital in question. We can do it. But then it depends on the severity of the event, and also we will have to take action accordingly. What we do must be proportionate to the severity of the event. Chairman, if the Director says that it's possible, I'd like to ask for the facts. In the past, have you ever done this before? Have you found out that there might have been reportable cases, but then they have not done so? So as a result, have you issued any warnings or whatever? So have you done that in the past? Well, you will have to give the Director the time to respond to that. Well, since 2011, the DH has already stepped up is monitoring, so that private hospitals are required to report the cases within 24 hours. And in 2011, there were 5 cases, and 2 were reported within 24 hours. For the remaining 3, they did so after 24 hours. And for the 3 cases, we issued warning letters to the hospitals in question. And in the future, for those who have failed to make the report within 24 hours, we will issue warning letters to them. But other than the 3 out of the 5 where warning letters were issued, are there any mechanisms in place for you to resort to a more independent way of collecting evidence, or to verify if some hospitals might not have been positive enough in following the guidelines? Director, well, actually every month we would receive reports from the hospitals concerning the reports that they have received, and in that report we would have doctors and nurses, and we would look into that to see if there might have been sentinel events. So there is a mechanism in place. Other than their reports, we also have our own complaints digest. So we also have our own complaints digest. We also check that, and we also receive complaints from members of the public, and we will also be able to identify if there have been cases that have been reported out of time. All right, would there also be a demerit point system in order to ensure that the mechanism will be more objective, so that even if the license might not be revoked right away, but then in the past, and if you look at the questions that have been asked by members during the 2 hearings, well, apparently they are all very concerned that there might have been a mechanism in place, but then you might not have made full use of it, and there might have been some impression that you might be defending your peers, or that you have not enforced the law stringently, and so on. But then apparently there is no objective criteria for you to enforce the law. So will you consider, even for public rental housing, they have this demerit point system, so that if they fail to do certain things, they'll have certain points deducted, and then there will be warning, and then by a certain time their tenancy might be terminated. So will you have similar policies or measures in place that will be considered by the working group, says the Bureau Director. Mr. Paul, Chair. All right, one final question. That is in answering the question raised by Mr. Alan Leung. You said that apparently you did not have a case in point that would allow you to pinpoint as to when you changed the measures, so that for the medical blunders, they would be directly referred to the professional bodies, and you would also go back to check your records to show when you have started that approach. So I'd like to get a clearer picture. That is with regard to notifying the hospital in question. Well, in the past, for privacy concerns, you would not be referring those cases to the professional bodies, but then since a certain time, because of the policy change, you'll be directly referring those cases to those professional bodies. So have you got any email? It's like the CE issuing emails to bureau directors, so that in future when they make appointments, they will have to inform or notify a certain party. So would you have such records? Director, we have not issued such an email. But then it does not necessarily have to be in the form of an email. Mr. Chair, can you ask that again? So instead of asking her whether there was such an email, you can also ask it in a different way. So has there been any record whether or not it's a meeting or an email, or have you had a meeting warning them that, well, in the past, because of privacy reasons, we would not be referring those cases to the medical council or nursing council, but then after starting from a certain time, we'll be doing this so that everybody will know that you have already changed your policy? No, we have not got such a meeting or such a communication. Chairman, then how would the private hospitals know? How would they know that you have already adopted this new practice, as the Bureau Director said in answer to Mr. Alan Leung's question? So how would they know that you'll be making direct referrals from now on? Well, for sentinel events involving professional misconduct, and if the patient agrees, then the principle of referring such cases has always been there. But then it's not about the doctor in question.
Perhaps let me follow up on this point as well. Just now, you explained very clearly to us and in reply to Mr. Leung's question, you said that your new mechanism is that unlike the mechanism before 2010, referral would not be made only on patients' requests. Now direct referrals will also be made. So have you ever informed the private hospitals? How would they know that the system has changed? So, young this part is quite important, so I'll give a little more time for them to finish the questions. Private Secretary. Now, as we review the regulatory system of private hospitals and on the necessary improvements, we will continue to closely liaise with private hospitals. And in the course, we will not issue one notice per incident. We hope that a holistic approach will be taken and when discussing with them on the improvement of the whole system, and before the work of the working group commence, we will keep close communication with private hospitals, and we will hold meetings with them before the formal revamp of the regulatory regime of private hospitals. For all these measures to be implemented under the new mechanism and the existing powers that we have, we will communicate with them. I have to ask for another minute. How can you do things only verbally? Well, you can say that you have tightened up the measures, it's now very strict, but there is no basis for that. You can just say whatever you want. It's unfair to hospitals, doctors and nurses. Why? That's why things are very chaotic. There is a lack of proactiveness. How can you ask the hospitals and doctors and nurses to follow? Secretary. Now, in fact, we have to communicate with hospitals on a lot of things. It's not just about the problem that we're talking about. And the principles are that if seasonal events are involved, and if there are cases of professional misconduct involved, then the cases will be referred. In the past, much importance has been attached to protecting patients' privacy or personal privacy, but now we think that we can ask for the parties' consent and take action. But it is not that simple. The patient must agree that he or she will take part in the hearings as a witness. So it's not the simple case of informing the private hospitals unilaterally. The principles remain unchanged. Secretary, I do hope you can explain about this as well. I got confused. Just now you said that if professional negligence is involved, there will be direct referrals. But Director, on the other hand, said that professional negligence and privacy are two different matters. Privacy trumps professional negligence. Can you tell us between the two? I mean, do I get it correctly? I don't quite understand, because it seems that what you say is different from what the Director has said. Well, one talks about the existing practice, one talks about the way forward. But I don't see any consistency here. Do I get you correctly, Secretary? It's important for our report, so your turn is coming, but let me resolve this matter first. Just now, Mr. Leung asked this line of questions in great detail. he asked about public and private hospitals, and now, on hearing your explanation, it seems that you are going back to the old path. So can you give us a clear answer? We may hold different views subject to your answer, and it might be unfair to you if we include this part in the report. First, Chairman, I need to clarify this. You used an English term, is professional misconduct, not professional negligence. Oh, let me clarify. I'm just a layman. I'm not a medical doctor by profession. I thought that negligence would lead to misconduct. To meet.
冇錯 profession 嚇。
你講嘅係啱嘅，即係兩個概念咧中。
You're right. There are overlappings as far as these two areas are concerned, but as far as professional governance is concerned, I need to emphasize that the Medical Council of Hong Kong is in charge of matters relating to professional misconduct. And medical negligence, on the other hand, is a concept applicable to civil courts. And I believe that some members are familiar with it when we talk about duty of care and a breach of this duty of care and substandard performance leading to injuries. This is what is called negligence. I understand that the record may be prepared in both the English and Chinese version, so I need to clarify this point. For the Medical Council, they looked over matters related to professional misconduct. All right, adopting your narrow scope of professional misconduct, your version is different from Director's version. Director said that privacy trumps misconduct. Do I get you correctly? Because the Director replied to Mr. Chair's question like that. Do I get it correctly? Secretary. Let me clarify. In 3.15, in 2010, the DH said at that time there was the privacy issue, but I think that as far as the present circumstances are concerned, my version is consistent with Director's version. We respect patient privacy, but when this case is directly referred to the MCHK, then as far as patient privacy is concerned, we will first of all ask for the patient's consent in disclosing information. And secondly, the patient or the complainant might be required to attend the public inquiry in the capacity of a witness if this case is referred to this statutory body. So for cases involving professional misconduct, the cases of sentinel events will be directly referred to the professional bodies and councils for investigation. There is no difference. What if the patient says he's not willing to do it, but in fact there is such a conduct or misconduct? Then what will you do? Because you're given this power under the ordinance. Just now Mr. Leung already made it very clear that the scope is very wide. Well, Chairman, you have raised a new point. Yes, this is a new point. It has to do with the point that we're talking about. If the patient doesn't agree or doesn't consent, and I'll see if DH would like to supplement, we may have to seek legal advice before referring the case to the relevant body. Mr. Mo-Yuk-man, I'm sorry. Paul, would you like to queue up again? Okay, I'll allow him to ask the question first. Chairman, I really need to follow up on 2 points. Now, the whole session is about the reporting mechanism. And the reporting mechanism must be based on objective standards that we can follow. Or if there are policy changes, for example, if a change is implemented for direct referral of cases, then hospitals, doctors and nurses should be informed that they need to be more careful, because apart from issuing warning letters where professional misconduct is concerned, the cases will be referred directly to the professional bodies and councils. This is a very important difference in terms of enforcement policy. If hospitals are not duly informed, how can you ensure that people will feel that you have already fulfilled your responsibility of enforcement? How can you put the blame on doctors, nurses and hospitals? Secondly, whether you call it misconduct or negligence, now as Chairman put it, if there is an element on the patient's consent in disclosing information, then, well, like Chairman said, the direction will be different. Is it still of paramount importance that patients' consent to disclosure of information is very important, so that if a patient does not consent, you will not go ahead with the referral? Or will you act like the Hong Kong police force, and that you will go ahead with the proceedings anyway? In the past, you attach importance to patient privacy, but now you place more emphasis on public interest. Is it the case? If this is the new direction, when was it implemented? Secretary. Well, what we are talking about is a general principle. If there is any professional misconduct of any medical practitioner, the case can be reported to a statutory body. This is a very basic principle. Just like a criminal offense, we can report a criminal offense to the police. I don't see the need to formulate a guideline for this purpose. However, in the past, there might have been over-concern on patient privacy, and an across-the-board approach had been taken. We only attached importance on patient privacy. But now, our practice is different. We do not think it's all right to have across-the-board and over-concern on patient privacy. And therefore, we will not issue a notice just for this purpose. However, I've also undertaken that even before the review in a year's time, before it's completed, we will be closely liaising with private hospitals, and we will also explain about this new change. As for importance to be attached to patient privacy, well, all along we have to assume that the patient would consent to it. But what if the patient doesn't consent? Now, on the spot, now I really can't answer you on that. If it involves a criminal offense, then as a layman with limited legal knowledge, I don't see any problem. If it's a criminal case that has to be reported, I will do that immediately. But this is a professional regulation subject to a dedicated ordinance by a statutory body. And whether I can do that under such context, I really can't answer you now. Paul, I'll allow Mr. Wong to ask this question first. Thank you, Chairman. Last time, during the last session of the public hearing, one final question was on the monitoring of sentinel events and I want to supplement on it. We know that this reporting mechanism is voluntary in nature, and the DH cannot monitor all the underreporting of private hospitals. As far as I see it, there are technical difficulties too, and for the omission in reporting, well, we're seeing problems. Now in 3.11, let's look at all the examples. Things are very clear. It wasn't until a month after the media reports about the case appeared that the DH took action. But in fact, under the regulatory regime, you can issue warning apart from issuing a regulatory letter. Just now, Secretary or Director has already replied to this part of the question. So just to follow up, if the private hospitals did not report the sentinel events in time or according to a time frame, would the frontline staff be accused of covering up the incident, or the middle rank of the hospital staff or the management of the hospital for the purpose of saving the hospital's reputation? Have you investigated into the cause of the delay in reporting? Secretary. Chairman, I think that it should be done, but I'll defer to Director for the details. Now, Director, you said that you would receive a report on a monthly basis. Now, Mr. Wong Yok-man has asked an important question. If there is a delay in reporting the events, we would ask for the causes. In some cases, they would say that the cases involved were complex. They needed to inquire with a lot of frontline staff in order to get the details. Now, as for the details as mentioned by Mr. Wong Yok-man, they may not be covered by our inquiry. But Chairman, do you agree to what I said just now? Has it to do with frontline or the middle rank or management level of the hospitals? Well, perhaps you hadn't been able to do that, but do you agree that it is necessary that you looked into the causes so that for the non-timely reporting in the future you can collect some data and do an analysis? Secretary. Just now when Mr. Wong asked this question at the beginning, I already agreed that this is what we should do, but we also need to understand the difficulties facing the DH in their investigation work and see how we can help them. Director, you have just a few staff for this investigation. Yes, the purpose of the investigation is on the cause of the sentinel event, so as to prevent the future possible occurrence. As for the detailed operations of individual hospitals and who should be responsible, etc., more resources are required. I understand, but it has to do with the sanctioning system. If it's covered up by frontline staff, then it has to do with professional misconduct, and the cases should be referred to the professional bodies. If it has to do with the cover-up by hospitals itself, then we should have a relevant sanctioning actions. But I also accept the Director's explanation that there are difficulties, and the direction of the investigation should be on the nature of the sentinel events. But I still think that we should follow up on that. Say if you have more manpower, or say if you have a set of procedures for this purpose. Mr. Wong Yok-man, we can put this in our recommendations in the report. All right, paragraph 3.11. I need to follow up on this. Like I said just now, 50 cases of delays in reporting of sentinel events, and DH only issued 3 regulatory letters. So it seems it was okay for these cases of delays in reporting of sentinel events. What are the objective standards for issuing regulatory letters in respect of cases of delays? There are more than 50 cases of them, and only 3 were issued. So you must have made the decisions because only 3 letters were issued. Only 3 regulatory letters were issued. So my question is, what standard did you adopt, or what criterion did you adopt? Now, the reporting must be made within 24 hours. At the time when we rolled out this new measure, it was not yet mature, and there were more cases of delays. In 2011, we tightened up the monitoring, and after 2011, for all cases with delays for more than 24 hours, we issued letters to these cases. Now, for 3.11, the example quoted involved more than 1 month of delay, and the case was reviewed on the 4th, and then the letter was not issued until the 31st. So you said you had already tightened up your monitoring according to the code of practice. The reporting must be done within 24 hours to the DEH or else. But we'd like to know what is meant by or else.
So we had 55 cases, and yet there were only 3 regulatory letters, and that's our concern, Director. Under the current mechanism, reporting is done on a voluntary basis. Therefore, what we can do is to issue regulatory letters or warning letters. But, Chairman, I think the Director has not answered my question. You have your objective criteria, and I asked you whether you have any criteria for deciding on when regulatory letters should be issued, and your answer is that our criteria is 24 hours. And in 2011, you can see from the data that it took on average 13 days, for the issuing of letters. So there's a gap there. Director, yes, we would further call on hospitals to make reports. Every year, we have a digest issued on patient safety, and through that system, we let private hospitals know we do attach importance to reporting of events and any lessons are learned. So we would strengthen our work to call on hospitals to make reports. Director, just then, Mr. Liang mentioned 165. But, Ordinance 165. But seems like you're only reminding or calling on hospitals to take actions. Chairman, Ordinance 165 stipulates that if the staff and facilities were not up to standard, then the licenses could be revoked. So we're talking about sentinel events that lead to revocation of licenses. But for the operations of private hospitals, we need to understand that these hospitals have various units and specialties. To revoke a license of a private hospital, that's a major decision. But we can issue warning letters to regulate them. So Ordinance 165 gives you the power to monitor these hospitals at different levels. It's not necessarily about revocation of licenses only. There can be various means to monitor their operations. So can you explain further, Secretary? Yes, Chairman. As members like Mr. Wong said, their points were right. But I want you to note that, as explained by the Director, in 2007, after we introduced the new measures, it takes time for the whole system to mature. But in the recent year, the DH has already been more stringent in monitoring, and they did issue warning letters. So you have to look at the direction of how things are going. Chairman, I think we can ask for concrete data from them. Since 2007, when the measures were introduced, things were not that satisfactory. But as time went, now that we have the Audit Commission's report out, things should have been improved. So we want to know what you've done and what concrete data you have to help with our writing of the report. Yes, Director, can you provide us with data? Okay. Okay, follow-up question. Can you look at paragraph 3.14? The electrical panel on health services has had meetings for several years, calling on you to follow up on the cases of non-compliance with requirements. So the Secretary or Director, can you give us an answer on how you're going to resolve the issue? We've had meetings for years, as mentioned of paragraph 3.14, and how are we going to settle the issue? Yes, Chairman, here it says that members express concern that private hospitals will not be penalized for non-compliance with the requirements of management of sentinel events or the issuing of advisory or warning letters. As we tried to explain earlier on, despite the various matters of concern, in the past there was no event serious enough to make the Director feel that they could use Ordinance 165 to stop issuing or revoking a license. But we are going to review the Ordinance 165 to increase the deterrent effect. Actually, I said before as well, what I hope to see is that we could bring in different levels of sanctions for events of different degrees of seriousness. Okay. Chair Ken. Chairman, at our last meeting, which paragraph are you referring to? Well, I talked about referral of cases, and I was very pleased to hear from the Secretary that they had dropped the defense of privacy. And I asked him then, have they reversed the previous practice? And I remember him saying, as put on record, that he said that we are taking a more proactive stance. And today, I was listening to the Secretary's answers to questions. I had the impression that he seemed to have gone a bit backward today. So I want to ask again, Secretary, can you make it clear, give a clearer answer to us in the case of a misconduct? Would you, with patient's consent, refer the case involved to professional bodies for follow-up actions, and that you would take the initiative to ask for follow-up actions instead of like in the past, even if a patient report to you a case of a medical event and you would say to them, oh, you need to get help for yourself, I can't offer you any help. So we're talking about a shift in people's attitude. In the past, even a patient asked for referral, the Secretary would not make such referral. But now, with Mr. Cole being the Secretary and now with the audit report in front of us, your attitude has clearly changed. That is, should a patient request a referral, you would make the referral immediately. Is that how the line is drawn, should be drawn now? Yes, I can definitely answer yes. If a patient makes such a request, that means he does not object to referral. So it's very clear. Mr. Alan Liang asked about when the shift was made. That is before, is it that before this Audit Commission report was out, the attitude was already changed? So there's no need for us to go back to look at the past data. Yes, Chairman, that's what I meant. Yeah, so we can be clear now. Now, since Secretary took up the Secretary position, the attitude was changed. So, Secretary, just then, Mr. they asked a right question. Would you issue a notice informing people about your new approach now? Because how are you going to communicate with hospitals? Chairman, as I said, let me repeat again that we're not talking about one single issue. We're talking about one out of many issues. So the working group would maintain close contacts with private hospitals, having meetings with all private hospitals, and when the talks reach maturity, and if it's what current law allows them, we would do what needs to be done. And we would also discuss widely with private hospitals, including the issue you just mentioned. So in the writing of our report, we need to put down very concrete information. We can't use, vague concepts. Just as Mr. Chair was asking you, would you issue a notice or not? If you're not going to issue a notice, how are you going to convey the message to private hospitals? Yes, Chairman, in the future, should we come up with when the new mechanism is introduced, we would definitely issue a notice. But if during our process of discussions, as we keep close contacts with private hospitals, I would not rule out any method of disseminating information or communicating. But I think that for matters of general principle, in the past, we attach a lot of importance to privacy, and the outcome might differ in the past. But the principle remains the same. Well, there's Paul first. I need to point out that the Secretary, excuse me for saying this, in the past, for many years, we had not, strictly enforced the law on illegal structures, and now you can see what grave consequences there are. So you can't say that once, we have changed, since we've changed the approach, I think to nurses, to doctors, to hospitals, to be fair to them, we need to, as soon as we can, especially now, the government, pledges, responsibility, and we need to convey the message and let people know soon that privacy will not be used as an excuse anymore. As I explained earlier, I will communicate. But if members want to know when I would issue a special written notice or letter, I personally so far don't feel that, issuing such a letter serve any purpose, because we're talking about a general principle here. Do we need to issue a special notice to serve the purpose? I find it quite difficult to do that. I don't see the need for that yet. But we are talking about a policy issue. Or are you concerned about enforcement or what? The director has the power to enforce the rule. You're given the power as director to enforce the law under Ordinance 165, but Secretary, do you see that, when you are there to regulate hospitals, when it comes to enforcement, it's like, Carrie Lam said yesterday or the day before, she had no power over the director of buildings, but you have the power as director. But how are you going to enforce your power? Well, Chairman, we're not just talking about this narrow issue of referral of cases. Well, are you going to answer, Director? Yes, enforcing 165. actually relates to enforcement of the law, on whether there's compliance with the law on staff and equipment requirements, and hospitals run the risk of having the license revoked. As for referring cases to MCHK or NCHK, this is a policy matter, and as the Secretary mentioned, the DH will enforce what is entitled to do. Well, thank you for your interpretation of 165. Chairman Paul, as I said, we're not just talking about the narrow topic of referral, but the Secretary all along, as he said in the past few days, you need not wait till the review is done before you can take some remedial actions. Now that the Audit Commission report is out, the point is what you're going to do to convey the message of what you're going to do to hospitals. Is it that like the point or the housing issue of 85,000 flats before, that no action will be taken as long as nothing is said? Secretary, if the member is saying or referring to the basket of measures, then that's a different matter. As we communicate with private hospitals, if there's a need for us to take any action or amend existing regulatory measures, we would try all means, including issuing a notice to let hospitals know. But Mr. Chair asked me whether we need to issue a notice on this particular matter. I can't give you an answer. Well, I don't want to waste any more time on this. I think they would do something, but whether it's as what you wanted, that's a different matter. But I think let's see if there are other questions. Well, supplements. I think we need to also look at this question of whether the authorities would periodically do some benchmarking against international criteria, for example, WHO criteria, so that we can update our existing approach. Yes, we would do periodical benchmarking. Any more questions? Okay, if not, then Ellen, your turn. Okay, 3.30. According to the COP, private hospitals need to submit a complaints digest every month. The digest is important because it allows the DH to know where there have been cases that were not reported or whether there were cases that require further investigations. If you look at the outcome of the audit review, the submission of complaint digest is not strictly followed. So I'd like to ask whether the authorities have taken any measures to ensure that in future the monthly submission of complaint digest will be followed. That is among the 11 private hospitals. And also in 3.32, the audit found that although DH noted irregularities in the course of its investigation of a number of complaint cases, it did not issue advisory or warning letters to the private hospitals concerned. So I'd like to put on record the authorities' response on whether you would make any undertaking on future follow-up actions, say on untimely submission of complaint digests, say if submission is late. I don't want to repeat details here as in case 3. It's quite a serious situation. Cases of a triple dose of medication or or as in complaint 3 concerning a case of blood collection. But all these cases were not mentioned in the complaint digest. These are serious events. So what can we do about it? And 3.37 related talks about Table 6 and 7 that show that staff performance and charges are the two major areas about which complaints were made against private hospitals. But can the director tell us? So now the Audit Commissioner has pointed out these problems. Would the director do a more careful analysis of the complaint digest? And should there be systemic problems, what would you do to ensure that the systemic issues after analysis can be made known to the management and get the management's attention?
Director. Chairman, paragraph 3.30 says that 5 private hospitals had not always submitted the complaint digest monthly as required, and we will be enforcing that stringently so that all hospitals will be required to submit the digest on a monthly basis. 3.32 for the 3 cases that have been set out under that paragraph. Well, after receiving the complaint from the complainant, we did take follow-up action, and afterwards we already gave verbal advice to the hospital concerned. But then with regard to the record, well, with regard to the verbal advice, actually we have got records in our files. And at the last meeting, as we have already said, for the 3 cases that are mentioned here in the paper, we already got records to say that we had given verbal advice to the hospitals in question. And in the future, everything will be recorded in greater detail. And yesterday, through the Secretariat, we have also given you a pile of documents. In fact, as you can see, every year we have the inspection summary, and we also set out in the inspection summary as to what verbal advice has been given. And in the inspection summary, after the inspection, we would also be enclosing data to the hospital during the license renewal process. Yes, I think the director is referring to R/59/J3. As regards 3.37, we saw the categories of complaints. So those are the categories or classification of complaints. But we also have to see if the complaints could be substantiated. In the future, we'll look into it. So, we would be looking at the classification of those cases to see how we can step up our communication with the hospitals. For example, on charges, this is also precisely what the working group would be looking into. That is about transparency of charges. That would also be one of the areas of review. And we are prepared to accept the recommendation by Audit. Yes, Mr. Allen now. All right, Chairman. I think we have already dealt with the first 3 parts of the report. At this stage, I would also like to share this view with you. Well, the director is in a very difficult position because I do sympathize with her situation. Let's imagine there are 11 private hospitals and there are so many departments, as the bureau director just said, and she only had 1 + 11 under the establishment of the department. So I hope that the bureau director and the director would understand this. That is the PAC and the auditing arrangements are here to help you to get adequate resources from the administration in order to respond to public aspiration. So it doesn't necessarily mean that we are being confrontational or we are at the opposite end of the table. Well, you can't have the cake and eat it, as the director is responsible for regulating 11 hospitals. Had there not been one that had closed down, you would actually have 12. So if there are no further questions, then let's take a break of 10 minutes. I think chapter 4 should be faster. All right, then we'll move on to chapter 4. Okay, so we'll come back at 11. All right.
Kenneth，你想唔想問問題？我哋
Candice, would you like to ask questions? We are already on part 4. Sorry, speaker's not coming through. All right, the hearing is resumed. Please close the doors. And let's wait for the Permanent Secretary to come back. Take your time. There's no rush.
係 Alan，唔該你。
Yes, Alan Leung, please take us to part 4. Yes, on part 3. There's one thing that I'd like the Bureau Director to consider. It's about making direct referrals to either the Medical Council or the Nursing Council by the DH. In fact, there are some cases in which you don't have to worry about patients not willing to give evidence because in some cases you have all the medical records available, and I think they are already very clear cases. So I hope that you can also take note of that. So that's the only point that I did not manage to get to. Now on part 4 is about price transparency in hospital charges. First of all, I'd like to refer the Bureau Director to para 4.6. Para 4.6 says that the audit mentioned that out of the many complaints, you can see that there are a number of areas where most complaints would be focusing on. All right, they were on unexpected price increase, unreasonable charges, and price information not communicated in advance to patients, including doctor fees. So my question for the Bureau Director is, what would the administration do in response to these main areas of complaints in order to improve the situation with regard to price transparency in hospital charges involving private hospitals? Chairman, we understand that the transparency in the prices of private hospitals has always been a concern of the consumers. So under our policy in the future, the Bureau is very clear about this. Of course, we are not supposed to have a say in their charges, but then we have to make sure that there will be transparency in their fee charging mechanisms. But we also hope that the public will understand this. That is, in some circumstances, the fees and charges might not have been as you wish. That is, before I go into a hospital, can I have a budget as to how much I have to spend? Well, in cases of elective surgeries, I think that should be done. In other words, before you're admitted to hospital, if you are undergoing an elective surgery, then we will allow the patient to know exactly or roughly how much he is expected to pay. But then after you've been admitted to the hospital, even for the same kind of disease, the day of stay, and also the kind of drugs prescribed might be different, but then at least the patient should have an idea as to how much he is expected to pay. But then in acute cases, when you're admitted to the hospital, there might not have been even a diagnosis, so as to how long he will have to stay in the hospital, what kind of drug will have to be used, and whether or not you will have to undergo certain examinations and so on. There is no idea in advance, and therefore it would be somewhat difficult. But then even so, when you're admitted to the hospital, if you have to pay for certain services or examinations, the patient should be informed in advance as far as possible. In acute situations, it might not be possible to do so. But then, even if you are not aware of that at the time of admission, but then by the time when you're in hospital, if the doctors think that you have to undergo certain examination, and if they are rather costly, then in due course they should be informed. For example, if the doctor suggests that you will have to undergo an MRI, and then this will cost you how much, then the patient should be told I think this is what the hospitals should do. Well, even though we're not there to regulate their prices, we will have to increase the transparency. And there are different ways to do it.
就基本
One basic step is to ensure that the private hospitals have made available a schedule of charges, at least in relation to hospital charges, for example, consumables and disinfectants, etc. All these charges should be made available for patients' reference. As to whether or when this should be made available, well, perhaps at the time of admission, the patient might not have access to this information, but at least before the operation was performed, the patient should be notified. As for other price information, for example, doctors working with private hospitals on a collaboration basis. Well, yes, there are resident doctors, but there are other doctors not attached to private hospitals per se. They have the right to amend prices in relation to patients' consultation and the relevant operations. And we are discussing with private hospitals and see how, for fees charged by these doctors, in particular for elective procedures, patients will be informed of the fees or charges beforehand. Mr. Lang. Now, for acute cases, you could not do anything about that. Well, we understand that. But according to the complaints about unexpected price increase and reasonable charges and price information not communicated in advance, just now, Secretary also mentioned this point. I'm not teaching grandmother to suck egg, but let's say gauze, how much, and if you've used 5 pieces, how much would that be? Of course, it's up to doctors to decide how many pieces you should use, 5 or 10. But the problem is there is a lack of price transparency. Even for the items to be used, there is a lack of a schedule of charges. Now, according to the websites of the 11 hospitals on the fees and charges, the Director of Audit prepared a table for comparison. You can see that they all adopt different approaches. So, pursuant to my line of questioning, will the Bureau, through the DH, urge the private hospitals to make available on their websites the schedule of charges, or at the time of admission, the schedule of charges would list out more items, and also the list would be sort of standardized among private hospitals, covering the certain scope, so that patients will be informed of this charges. Do you agree, Secretary? I agree with this direction. As I said at the beginning, for hospital charges and the breakdown, priority should be given for this information to be accessed by patients very easily. As for other information, after admission, there might be changes in these items, and still price transparency should be enhanced. Mr. Lau, well, I'm happy to hear that Secretary also agreed with this direction. So is it the same case that Secretary will have it implemented as soon as possible? Yes, will you introduce it as soon as possible? I think that's the same principle. If after discussing with private hospitals they are willing to cooperate with us, then we can introduce this measure anytime. Alan, any more questions? I'll let other members ask questions first. Mr. Chen, I can. Chairman, in 4.6, 4.7 of the audit report, most of the complaints had to do with charges. So, Secretary, how will these complaints be followed up? Will there be any follow-up action? Or would you tell them that you had nothing to, there is nothing you can do about charges? And how are you going to follow up on these cases? Would you issue warning letters, and would patients be able to get a refund? If not, would you just be helping private hospitals in making profit? Secretary, let me reiterate the principle. I need to clarify this point. We're talking about price transparency of private hospitals. We will not regulate the pricing or charges of private hospitals because this is a private market. So it is difficult to determine whether the hospitals are charging excessively. Does it mean that you are unable to handle complaints in relation to fees and charges? Secretary, I think the way we handled the complaints is to do the best we can to enhance the price transparency in hospital charges. Well, please let Director supplement his answer first. Let me supplement. There are cases of complaints in relation to doctors' charges, not hospital charges. And after providing emergency services, some patients were not happy with the hospital charges. And we think that without affecting the treatment given to patients, the hospitals should communicate the price information to patients as far as they could. And sometimes mistakes were involved. There might be an error item on the bill, and upon follow-up action, the situation had been rectified. So, according to the Code of Practice, private hospitals are required to make available a schedule of charges for patients' reference. So, for this schedule of charges, apart from the website, are there any other places where the patients can find this schedule of charges? Will it be placed inside the hospital? If other channels are not available for patients to get hold of this information, then my concern is that sometimes the schedule will be prepared in small prints, or it may be very long, so that despite having this mechanism or schedule of charges, no adequate protection can be provided to patients. Secretary, as I said just now, in relation to the schedule of charges, for hospitals, as far as practicable, different channels should be provided for patients to get hold of this information. But if it involves a long list of charges, and if we require them to print it in large font size, it might be troublesome. It might not be a schedule as such, but a booklet. So the most practical way is to make available this schedule online on the website. And when we discuss with private hospitals in the future, we have to come up with ways so as to provide price information for patients' reference through more channels. Yes, Mr. Chen. Table 8 provides a list of package charges offered by different hospitals. Just now, Secretary already said that extra examination or procedures might have to be carried out depending on the patient's conditions, and it's difficult to set down a fixed price, and we understand that. But in relation to packaged charges, can you provide more information other than that set out in the table? For example, in page 38 in the Chinese version of the audit report, the Director of Audit set out an example of provision of price information in Singapore, so that there is an average average price information and what the estimated total charges are likely to be. And can we follow this model? Secretary. Like I said just now, the administration will not mandate package charging in private hospitals, but all along we have been encouraging this practice in private hospitals. It also helps in their operation. So as you can see, quite many hospitals are offering packaged charges. For example, obstetric packages in most of the hospitals. As for elective procedures I mentioned, many hospitals are indeed offering this service on packaged charges. For doctor affiliated to these hospitals or resident doctors, packaged charges can be negotiated. The problem with package charges, however, is that the patient must understand that packaged charges will exclude any major unanticipated incidents happening. For example, if there are serious complications, unexpected, which arises, then this might fall outside package charges. Mr. Chen, you also asked whether we will make reference to the Singapore model. Secretary. Yes, we will draw reference from other jurisdictions. Singapore is one of them, but we will not just follow any one country's example. Next, Mr. Wong Yuk-man. Thank you, Chairman. I'd like to discuss one sentence with you. I don't quite understand. Yes, please read out the sentence. We know that in the Code of Practice, it says that after receiving consultation or any medical procedure in a private hospital, a patient has the right to have access to price information. Now you told me that between 2009 and 2011, in terms of the price information of the 12 private hospitals, the DH did not find any irregularities. So when we compare the two sentences, according to the information between 2009 and June 2011, in relation to the provision of price information by private hospitals, the DH did not find any irregularities. On the other hand, in another sentence, patients on receiving consultation on or medical treatments in private hospitals have the right to have access to price information. So does it mean that no private hospitals had ever breached this requirement, as I quoted? But as we know, there are 351 complaints related to charges, and many of them focused on unexpected price increase and reasonable charges and price information not communicated in advance to patients. So do all these three areas constitute breaches or irregularities? Do these three areas amount to irregularities? Secretary. Let me respond to this question first. Whether a patient has a right to information, of course, they have. But it also depends on the circumstances. For example, before carrying out a certain procedure, a patient should be informed the feasibility. For example, the actual condition of the patient, or whether there are any changes concerning the patient's condition before and after the admission. And I'll defer to Director to supplement my answer. Director, if a complaint is about charges, very often we learned that the complaints had to do with doctors' fees instead of hospital charges, because for hospitals, very often they had a schedule of charges, and there is a note to admission, and that included the schedule of charges. Very often disputes arose from doctors' fees, because doctors' fees wouldn't be determined until the patient had actually been consulted the doctor. And also for emergency services, sometimes the procedures were performed and the bill was later prepared. But so it's not the case that no prior communication had taken place. Now, when we regulate private hospitals, we regulate hospital charges, not doctors' fees. And for some emergency procedures, they were performed before subsequently a bill of charges was prepared. Yukman. So, the so-called requirement is that you should inform them of the price beforehand, but for other ad hoc charges, doctor's fees, etc., when patients weren't happy with the charges, they could then file a complaint. It seems that you're explaining for private hospitals, but according to the Audit Commission, the complaints were mainly focused on unexpected price increase, unreasonable charges, and price information not communicated in advance to patients. That's the result of the audit report. You are saying that there is no irregularity. And when I asked you, you said that because of some emergency situations, procedures or operations were necessary, and the charges were added on later. Well, of course, for patients, if after the operation they recovered and then they were not happy with the charges, so they complained. And now your reply to me is that there is nothing wrong if patients complained about these, because you already explained to the patients. Secretary and Director both gave this explanation. That's because extra procedures, extra medical treatment were given, and extra charges were incurred. So it seems that as far as complaints were concerned, for complaint cases handled by the DH, and you did not see any problem in the problems identified by the Director of Audit. Secretary, there are actually two scenarios. The first scenario is that the patient might have information of the prices at the time of admission. So in terms of this complaint about price information not communicated in advance, my attitude is that patients did have price information beforehand, but the patient's condition might change before and after admission. Stemming from which extra procedures might be necessary and extra charges might be incurred as a result. That's a different matter. of not explaining in detail the price information to patients. So as far as possible, even if all of a sudden extra procedures were required, the hospitals should nevertheless try to explain to patients. At the time of admission, the doctor might not have foreseen extra procedures to be carried out, and when they form this view, they should inform the patient. You maintain the similar stance during the audit's investigation. So in terms of enhancing the price transparency in private hospital charges, improvements have to be made. In fact, for sudden price or unexpected price increase is actually a contravention to Section 16A1 of Cap 210, and that's a case of defraud. That's an offense of defraud. Man, you're not in court today. I'm just saying that there is a problem with unexpected price increase or unreasonable charges. When we regulate private hospital charges in the code of practice, there are lots of loopholes. I just want to point this out. There is a loophole.
So I feel that there is a need to perfect the system. I know what you're saying in your answers, because under existing law, there's nothing you can do on the pricing, because the COP is so general. The COP only says that you need to provide prior notice about the price. That is the price for surgeries and so forth. But we have received these complaints about unreasonable or unexpected price increases. So we can see whether we can plug the loophole in the COP. Are you making a recommendation? Yes. Okay, Secretary, you want to answer that? Well, the COP, if there's room for improvement, we can improve it. But I'd like to explain that the lack of prior information on price increases could be due to various scenarios. For example, if a patient's situation deteriorates after admission into a hospital, if there's a need for an extra surgical procedure, then these actually scenarios can happen. But unless it's impossible, these possible scenarios should be made known to the patient beforehand, either before a patient is admitted or after patient is admitted. So even, I think, before any procedure takes place, the patient should be informed of the additional charge. Any more questions? Lansing. Yes, I think price increases make up by a notable number of complaints. Manners or attitudes are more subjective. So I think as for systemic issues, pricing is one area of concern. And in the future, we need to note, the rising aging population, and more people would need hospital services. So we need to make sure people do not be not flooded with unreasonable price increases. $186,000. That amount, is that enough to cover medical expenses? I think we need to look at this overall societal issue. Well, we'd like to thank the Audit Commission for giving us information in Singapore. For example, to ensure that each patient, when they are admitted or before they're admitted into the hospital, they are aware of the possible bills or estimated bills for hospitalization. So an estimated bill, if it's lag much behind the actual costs incurred, then this would be a source of unexpected price increase. So how can these administration avoid such big gap in expectation and actual pricing? Or do we need some kind of regulatory control or adjustments? What mechanisms can there be? Rights or responsibilities for hospitals. This is quite a big issue, and so I'd like to ask, the administration whether you would consider make reference to suggestions in paragraph 4.17. That is, for example, amend the COP to enhance the price transparency of private hospitals. Is it enough to take measures alone without amending the COP? Can we, or can the administration, through the department, uniform the pricing for certain items? For example, can we have come up with a form for all hospitals to fill in to report on the standardized criteria for charging for various items of services? Do we need to have a uniform price list and also provide channel for the public to inquire about the pricing for various types of services? So once the price information is reported to the department, and should there be changes on the part of the hospitals need to inform the department of any price changes. Because now hospitals charge differently. Of course, that's possible in the private market, but once price information is reported to the department, then should there be future adjustments, then information should be provided to the department, or the department should be informed of any changes. And if the public wants to make inquiries, there should be a hotline made available to the inquirers. This is a way to enhance transparency. So I'd like to ask the administration whether you can come up with such or similar measures of unifying pricing information before the COP is revised. Secretary, as for private hospitals providing information on its pricing for various items, I agree that we should try to come up with some kind of format for parties to follow. And how we can achieve this without revising the COP, or should we revise the COP or amend the law? I think this is something for the working group to discuss. But I think we will choose to follow the option that we need to consider how we can correct the situation through simple means. So can I ask the auditor to explain to us the proposal in 4.17? Is it that they're proposing a sunshine policy, or what? Can I ask the auditor to explain further? What's your recommendation about? Thank you, Chairman. I think, as the Secretary just said, we want to enhance the price transparency, and if possible, we like to have a uniform format for the hospitals to follow. We're not trying to limit the prices charged, but we want to see that before a patient is admitted into a hospital, he knows what he can expect. Yes, I agree that it's good to have a uniform format. Charging information on standardized items. So, we can have hospitals fill out the same form and to put on their websites or post outside its cashiers on the pricing information. So we can have available the most up-to-date pricing information of various hospitals. As for the details, specialized items, we can offer a hotline for people to call so they can get immediate information by calling that hotline. So maybe we can have a working group to look into these and agree as soon as they can on the way ahead. Secretary, I think I agree with members and the Director of Audit's view that we can get private hospitals to provide a uniform price list. We also ask hospitals to let us know if they are making any changes to any of the prices. And your second point, what's your second question? Let me put it this way. Well, let us talk about... Well, he hasn't answered your second question. Well, it is about having uniform pricing information. That is, if there is to be an update later on, the changes should be made known to the department. Yes, I agree. Yes, so we agree. We're not talking about unifying pricing, but unified format. The same format to be filled in by all hospitals. The pricing for various types of services, so that there won't be a variety of different types of services being charged by different hospitals. Yes, I think after agreeing with Mr. Ng and the Director of these recommendations, I also want to point out one thing to avoid confusion. We are talking about provision of pricing information by private hospitals, but when a patient enters a hospital, what types of services are required, whether a private hospital can tell a patient beforehand the extent of services he needs. That's another issue. We need to stick to the principle that, for example, in some for items, for example, for MRI, what is the pricing? We need to provide information beforehand. But when a patient is admitted, whether he needs a certain kind of checkup, when a patient is admitted, he may need to have an MRI first. But for some patients, an MRI is only required after some time the patient is admitted because of a change in his medical condition. So the patient may need to pay an additional or an expected thousands of dollars. That's understandable. So I hope that should a scenario like this happen without the patient knowing beforehand that he needs to have this additional service, then that could also be likely. So we are talking about creating a uniform format of submitting to you the pricing information at private hospitals. Now, another follow-up question. For new hospitals, you are requiring them to require 30% of the bed days be subject to a certain charge. But what is your rationale for the 30%? And also in paragraph 4.15, you said that the new requirement only apply to new hospitals. But would that be unfair to all hospitals? Chairman, my understanding is that the 30% you can't actually work out the 30% out of any pre-existing mechanism. This is a rough estimate, because I can do a rough estimate of the percentage of inpatients who are getting services provided through standard beds at packaged charges. Each doctor has a different number of patients, and each hospital's services vary. Therefore, this is only a percentage based on some professional estimates. Whether this is feasible, it all actually remains to be seen whether hospitals can reach this percentage. So does it mean that we will need to do a review or adjustment after some time? Yes, as I just said, we need to wait till the new hospitals have been in operation for some time before we can do an analysis on whether this 30% percentage is feasible. So the new requirement applies to new ones, but would that make things unfair to old hospitals? Well, this is something to do with the conditions in land leads. So we can't impose the new requirement on existing hospitals, but we encourage them to do the same. I think in the next report you can follow up on this issue. I think Paul Chair next. Having heard from the administration's response, I think there are just three concerns here, or potential difficulties. One is the free market, and second is the doctors and hospitals' responsibilities, and thirdly is unexpected procedures or medical procedures required. In the report, two hospitals are actually providing prior information on doctors' charges. In the U.S., like in the province of Wisconsin, there are 75 regular surgeries. The common procedures are available. The cost for 75 most common procedures are available on the website there. So that's a kind of transparency. Of course, doctors and hospitals are different. It's much easier to regulate hospitals, but it seems that the complaints target at unreasonable or hefty charges by doctors. So hospitals provide the facilities for surgeries, but the problem is there are many complaints against doctors charging or overcharging their patients. So hospitals are given preferential terms for providing services, or some hospitals are in a partnership. So the HA or DH, when it comes to partnership or granting land to hospitals, shouldn't they do more to avoid doctors from overcharging the patients at hospitals? Secretary, just then Mr. Chair talked about the differences between overseas and local situations. I'd like to do some explanations here. In some hospitals, different hospitals have a different ratio of doctors in residence. Some hospitals make use of their doctors in residence or doctors based there. So they're in a better position to provide package charges. But overseas, HMO model is more common, and doctors are bound by contracts with the HMO, and so the contracts can impose limits on doctors' charges.
This explains why in Hong Kong, most of the private hospitals would have the system of doctors doing the rounds in the hospitals, and as I said, through such agreements, we hope to be able to reach a consensus with more doctors, so that it's not just the hospitals, but also with regard to doctors' fees, there would also be a higher degree of transparency. Yes, under 4.14, we talk about the 30% package charges, and these are the new sites for new private hospitals. Both you and I are members of the University of Hong Kong, and we have also taken part in some projects in West Kowloon, and therefore I think it's good for us to make a declaration of interest here. Yes, it's under the rules of procedure that we will have to declare. Yes, I'm a court member of Hong Kong U, and Hong Kong U might also be one of the interested parties in bidding for the hospital site. Yes, between doctors and hospitals, there is this cooperation agreement, and there are chances for doctors to have or to do operations or procedures in a hospital, and therefore there is a chance that you'll be able to make sure that doctors' fees would be more reasonable, and there would also be more transparency, and where there is dispute, there can also be arbitration or mediation and so on. So in the past, have the private hospitals not done enough in terms of coordination, and also have you done enough in terms of your monitoring? Bureau Director. As we just said, we are not supposed to control the charges. And when there are package charges, then it's not just about transparency, it's also about the charges that have been imposed. And if we want them to introduce package charges for different doctors, they will look at their own experience and qualifications, and they might impose different charges. And therefore, number one, the hospital cannot say, well, in doing a particular procedure, you can only charge this fee. And therefore, for different doctors, if they have different charges, then for the private hospitals, according to the rules of a free market, the hospital cannot dictate what the doctor charges. And therefore, the hospital is not in a position to offer package charges. For example, if it's a hospital offering the packages to the patient, then of course there would be uniform charges. But then unless the private doctors are willing to package charges with or align his charges with the package fees of the private hospital, there is no way that there can be standardized charges, and therefore we are not going to regulate their charges. But then for private hospitals, as you just said, it's true that they've allowed the doctors to do the procedure in their hospital, and therefore the private hospitals should make sure that for the fees charged by the doctors in doing the rounds at the hospital, that should also be made transparent. There are two aspects to this. Number one, for the patient and any consumer getting the services, he should be informed of the charges in advance. And also the private doctor would also have this responsibility. That is, before you do a surgery or an operation on the patient, you have the duty to let the patient know exactly how much you will have to pay. So through private hospitals and also their relationship with individual private doctors, we hope to be able to enhance the transparency of the fees or charges that the patient will have to pay. It's not about the doctor informing the patient how much he'll be charged. By transparency, we mean that the public will have to know for this doctor or this category of doctor how much they'll be charging. Because of free market forces, if the hospital is willing to do it, and if the private hospital is in a position to do it, then we can use the forces of a private market. For raw doctors using my operating theatre, you will have to inform the patient as to how much you'll be charging, and you should not exceed a certain level. And even for individual doctors or surgeons, well, they might not be allowed to do that, but then as the hospitals enjoy special status, and therefore they can also be exempted with regard to the advertising restriction. And if you want to come to my hospital to do certain procedures, you will have to do this and do that. I think in doing so, that would be very helpful to many customers and patients, and that is also very much the core of the problem. Why can't this be done? All right, Paul, this is our suggestion. We can say this in our conclusion. But then I'd just like to know more. I'd like to give the opportunity for the administration to respond. Why can't this be done? All right, this is just your personal comment. So you can choose to answer or you can choose not to answer. And if you choose to answer, please be brief because time is running out. All right. Well, when it comes to regulating the charges of a doctor that cannot go beyond a certain level, I would say that I would not consider that. But then can others be considered? For example, can we allow the market to know a bit more about the charges by individual doctors? Well, that can be considered. Paul, any further questions? All right, when you try to rush me, I just forget everything. All right, I think you've already gone beyond that. You should be able to cope. Well, Chairman, the most important thing is, apparently in the past, well, the mechanisms that we used to have, including the code of practice, well, in the report it says that it's a toothless tiger because in terms of regulating the prices, the COP is simply not able to do anything. But then my view is that DH, well, through its regulatory mechanism of private hospitals, in fact, through free market forces, there could also be checks and balances. So, for example, when doctors use their venue, use their facilities, the private hospitals can also regulate their fees and charges. But then the bureau director said that he would consider it, but then he did not say why in the past it had not been done. Is it that for doctors and also lawyers, when it comes to human lives or people's freedom, then they will be able to charge whatever they want, because we're talking about somebody being arrested or patients are having to undergo certain treatment and so on. Let's not forget that these private hospitals have been granted a site at a nominal premium, so they have been granted sites without having to pay, and therefore if there are these conditions, at least theoretically, we should be able to impose certain conditions so that doctors would not be able to overcharge patients by making use of those facilities. Well, I was referring to the transparency of prices and so on. Yes, I do not differ from members, but then when it comes to the level of fees and charges, I cannot agree. Why do you not agree? I think it's a free market. For example, if a doctor says that I'd like to charge this fee, and if the patient agrees, then in principle, we would not ban him from doing that. But then I'll resort to other ways and means to enhance the transparency. And also, it's not like what Mr. Chair just said, that is, private hospitals have not done anything at all, or we have not done anything at all. If you can take a look at the tables, why have we managed to get those? Well, that's because on the one hand, the hospitals have also worked hard, and we have also talked to the hospitals. We have encouraged them to do so. That's why, as you can see, in Table 8, if you look at the hospitals, a total of 7 hospitals are here, and they do offer package charges, and that has not taken into account those offering obstetric services. So that has been achieved in recent years. It shows that both private hospitals and the authorities have made our own efforts, and we have also encouraged them to do it, and as a result, gradually they are more willing to offer package charges. I also agree with what Mr. Chair just said. Yes, despite the package fees and charges, there might have been private doctors doing the rounds in the hospitals, and they might be charging patients differently. But then there would also be pressure from the free market, as I just said. Well, for private hospitals themselves, for resident doctors that they have, and also for private doctors doing the rounds, well, they might be charging differently, but then all these would be shown in the scale of fees, and then patients would know, and then there would be pressure on the part of the doctors, but that is not regulation per se. And therefore, I agree with most of what you said, but then we will not go as far as regulating the fees and charges, that is to stipulate the fees and charges. Yes, Mr. Kenneth Lam. Thank you, Chairman. Just now we talk about regulating the fees and charges. I agree that this is a free market, and therefore we should not be regulating the fees and charges. But then when it comes to transparency, I do have some views. If you look at the whole incident, I think the core of the issue, or the core of the problem is, as the Bureau Director just said, is for non-resident doctors or even for non-resident anesthesists, well, in a procedure, there might be some complications, and then they will tell the patient that there would be additional charge. But then for this additional charge, you don't know how much it will be. All right, even though you have told me that there would be additional charge, what's the point of it if I don't know exactly how much I'll be charged? Well, for individual doctors, they would have a price tag. For example, let's say for Mr. Alan Low, you might say that you might think that I should be charging you $20,000 per hour of service. But then for a doctor, thank you for telling us. Well, for a doctor's experience, his qualification, and how much time he spends on a particular operation, and of course, it depends on the complexity of the operation. We have no idea as to how complicated this is. But then, resorting to what I just said, all right, if this hospital and the doctor, this is a non-resident doctor, if they have an agreement, and if the DH says that, well, in this contract or under this contract, this private hospital and the private doctor, for every hour of service, he can only charge this. And of course, this is indicative, because when you have an operation, it can be very time-consuming, because it can be there might be complications. So you'll be able to tell whether or not the doctor has overcharged. Well, for raw professionals, for the purpose of defending their own interests, they would not be willing to tell exactly how much they'll be charging, whether it's an accountant, a lawyer, or a doctor. All right, they would not say that, all right, please do not bargain, I'll charge you $600,000. But then for this operation, it has to do with his experience, qualification, and how much time he spends on this particular case. It would be proportional. All right, in cases where a junior doctor is involved, of course, the fees or the charges that he will charge will be different from an experienced doctor. But then I hope that the administration will consider this. Well, you will have to regulate the contracts between the non-resident doctor and the private hospitals. Would you be stipulating the format so that the doctor will enhance its transparency? For example, if it's not a package fee, then for every hour, I'll be charging you how much? Can that be done? Bureau Director, for private hospitals and also for the doctors doing the rounds, will there be clearer contracts between the hospital and the doctor? That will be considered. But at present, there is no formal contract per se. For private doctors, they will have to apply for an admission privilege from the private hospital, and then they can admit patients to that particular hospital. It's not a formal contract. All right, please wait till after he has given a reply. As regards how that can be regulated in terms of the relationship, can that be further clarified? I can look into it. But then for the time being, forgive me for saying this, that is, I will not consider regulating the price that will be charged by individual doctor on an hourly basis, because even if so, you will not be able to regulate the situation. Because for private doctors, if they want to charge a patient a price that has not been communicated to the patient in advance, well, if there is an operation which might last longer than expected, well, even if I tell you that I'm going to do an operation on you, well, instead of spending 2 hours, it might have cost me 4 hours, because this is something that I would not have been able to anticipate beforehand, right? Well, I can understand if it's a 20-hour operation, then of course the patient will know. So my impression, I've also received this, for the bill, he just spent a minute or so, but then I was charged more than $2,000. All right, I would be able to then calculate that if I have to pay $2,000 for a 2-minute consultation, then I will know exactly, or I have an idea as to how much I have to pay. And of course, if you say that I'll have to charge a certain amount for a 30-minute operation, if there are complications in the course of the procedure, then of course that cannot be anticipated. But then the patient will have to know it, and then he'll be willing to pay, and that will also reduce the possibility of the dispute or any disputes that might arise between the patient, the hospital, and the doctor, because for the time spent is an objective fact. I also have a more general suggestion for the administration. That is, in the future, when you grant sites or for new hospitals, can you consider this? That is, the hospitals should at least be required to offer certain basic packages, and there should be requirement that such packages would have to be offered to the patients, and they would also have to be in line with the certain pricing principles before the license can be issued. All right, thank you. Is a comment. First, on the hourly charge, I think my stance is very clear. On the second part of it, well, with regard to the 2 sites for new private hospitals, if you look at the tender documents, we have already said that a certain percentage of procedures will have to be offered at package charges. Yes, Mr. Lang? Yes, I'd like to ask this. I can see that if you look at many packages offered by private hospitals, some of them would be rather simple. Say, obstetric services, there would be charges for certain procedures. Well, looking at what Mr. Chair just said, in Wisconsin of the U.S., they actually have 75 most common procedures available with package prices. All right, well, 30% is what you propose, but then you're not going to enforce it. Well, I think it's just a lip service. It exists only in name. So my question is, can you go a bit further? For certain procedures or operations, can you stipulate that these private hospitals will have to offer them or will have to provide them at package charges that would help those with less means? Bureau Director, once again, I'd like to state this. At present, in private hospitals, I believe that it's not possible for us to stipulate as to the charges imposed by private hospitals, but then we do encourage them. And as I have been pointing out, that in Table 8, in recent years, actually, with our encouragement and also with the hard work of the private hospitals, more and more hospitals have now introduced different package fees. And as I said, in the U.S. and in other places, they might have different charges mechanism, but then we should not directly compare ourselves with them. I think the Bureau Director has misunderstood me. I have no intention whatsoever on regulating the level of fees and charges, but then at the time of granting the license, you will have to consider this. That is, for the private hospitals, they will at least have to offer 10 or 20 package fees or charges before you issue the license. I'm not saying that you will have to stipulate that they can only charge $50,000, $100,000. That's not my intention. Well, this is his personal comment, and you can take on board. Yes, in the new private hospitals, we have already done that. Yes, Mr. Kenneth Lang, no further questions. Mr. Alan Lang, all right, we'll draw a line after your question, and then we'll have to move on to the next part. I think we can wrap up our discussion on this part today. Yes. All right, you're on the same paragraph, right? Yes, I'd just like to ask this. Well, I think consumers know their rights better now. And also private hospitals also have to compete with one another. So there is competition in the private hospital market. And therefore, at this juncture, if you try to push them a bit, asking them to enhance the transparency, and if you require different hospitals to disclose these details in a standardized format, these are objective facts, then I think it will not be difficult. I think you're just doing what they're going to do anyway. And as you just said, for new private hospitals, through the tendering exercise, then you can also impose certain conditions, and through the lease terms, you can also require them to introduce this pricing mechanisms. It's like what has been suggested in 4.14, that is 30% of the inpatient bed days taken up in new hospitals each year must be for services provided through standard beds at package charges, so that new private hospitals will be regulated through these new approaches. And then what you have in mind can be implemented. But then for the existing 11 private hospitals, as you know, every year they will have to apply for re-registration. So in doing this, and if you find that one or two hospitals might be more resistant to this demand, then through the re-registration exercise every year, is it possible for you to exert more pressure on them? Do you intend to do that? Bureau Director, well, when it comes to exerting pressure on them, I think we try to look at it from a more constructive angle. So instead of waiting till when they come for re-registration, we can always talk to them. But then as a condition imposed on them, well, under the existing mechanism, I don't think that can be done as a clause or provision in the license or what. But then whether you call it pressure or coercion, we will definitely do it.
Mr. Wang Yuk-man earlier said that in the Code of Practice there is such a requirement. Of course, if there is any departure from the Code of Practice, the administration can use the COP as the starting point in order to enforce the requirement, just like inspection and rectification or remedial action. Chairman, I'm going on to part 5. I want to clarify one thing on the declaration of interest. I am on the council of the Hong Kong U, and I'm also a member of these few companies, Sin-chang and Hip-hing. I don't know whether I need to declare it, but I am going to declare it anyway. Okay, Ellen, you can move on to the other part, part 5. Well, this will be very brief and simple. I think the Director of Audit is doing his audit on the regulatory control of private hospitals. So for part 5.2, the Director of Audit asked whether performance indicators can be formulated and it should be done in terms of intended outcome, or to indicate the extent to which the department's operational objectives are being achieved. I stand to be corrected by the Director of Audit. But say in terms of the annual number of complaints received every year, will this be one of your targets? And will you say use a reduction in the number of sentinel events reported in private hospitals every year? I believe that this is what the Director of Audit is talking about. Will the administration introduce any objective targets or indicators, or will a target-oriented approach be taken? And can you tell us something about it? Well, let's ask the Director of Audit whether that's what he means first. Director of Audit. We are laymen in this regard. The Bureau and the Department should carefully consider the measures to be adopted in reflecting the performance. However, on gauging the performance, for example, on the handling of complaints, how many complaints were handled, and whether there would be any reduction in the number of complaints, these could be used as indicators to measure the performance, but it's subject to the department's consideration. In 5.7 of the audit recommendation, the DH should develop appropriate effectiveness or outcome indicators in respect of the DH regulatory work on private hospitals. So in terms of enhancing the transparency, or that the reportable events should be reported, well, this will be taken into consideration. The other aspect is indicators for the performance of the Director or the Department of Health, and these indicators will be formulated. But one point raised by Mr. Leung is in relation to an example. If we target a particular private hospital and that the number of complaints should be reduced, I don't think we are in a position to do that. Mr. Leung. Well, in short, we ask for a qualitative change. How can we show this qualitative change through quantitative indicators? This is why we're discussing with the Secretary whether it's possible to design some quantitative indicators and how these quantitative indicators can reflect qualitative change. Secretary, to quote a previous example, for example, a figure on the number of complaints should be submitted to us every month, and then we checked whether they meet the target every month or over a period of 12 months. Yes, I think we can formulate some indicators like that. All right, if we agree, this recommendation can be put in our report. But you have asked him this question, and if we could give us a reply, then all the better. Well, if he can't give us a reply now, then we still need time to compile the report so Secretary can supplement the information later. For example, saying that the administration has considered this issue and has these points to follow up on. I don't have many questions on this part, so I'll move on to the other part. That is part 6, the way forward. Well, it's somewhat related to part 5. I'd like to ask the Director of Audit. In fact, at the meetings of the HSP or on other occasions, members have followed up on the matter, and this is a good platform to show how the executive is accountable to the legislature. And through the years, we have attached importance to minimizing the discrepancies between the public hospitals and private hospital systems, protection of the patient's rights, and I dare say that from this audit report, the executive has not fully addressed the concerns of this council on a number of key areas, and we expressed dismay in this regard. But for the way forward, Secretary, say for example in para 6.7, the recent developments in relation to the land grant conditions in the new land leases for private hospitals in relation to the bed capacity and land size, service scope, package charge, price transparency, etc. and etc. There are detailed specifications. So, Secretary, for new private hospital developments, this can be the starting point to ensure that these requirements are met with to protect the citizens' rights. And as for the existing 11 private hospitals, apart from encouraging them to comply with the requirements, what measures does the administration have in ensuring compliance? Because you're not going to renew the land lease and that they have yet to expire. So you have been telling us that you're going to encourage them, so on and so forth, but what exactly do you have in ensuring compliance? Well, according to para 6.7, this is a new model. And for new private hospitals, their operation will continuously be improved. As for the existing private hospitals, the fourth working group under the steering committee is set up to review CAP 165. I'm not saying that all measures must be introduced through legislation, but when we consider improvements to be made and the mechanisms for introducing improvements, we also consider what measures can be introduced through administrative means and what others must be done through legislation. Secretary, before legislative amendments can take place, Secretary said that they would try their best to use administrative measures to implement changes. And he reiterated this point time and again. The good thing about legislation is that the LegCo can be a direct battlefield so that consensus can be forged. And this is conducive to the monitoring of existing private hospitals. As for the existing powers vested in the Bureau, it is not sufficient so that you are in a straitjacket. I don't quite agree. Is there any questions from other members? If there are no other follow-up questions, if there are matters to be followed up, you can provide information in writing or ask the questions in writing for administration's reply. Thank you. The administration and members, perhaps the meeting is now adjourned. Thank you.
Thank you. 我哋唔使走去第度睇下清晒場，我哋傾兩句好嘛？兩句好快啫，我係10:9之前講俾你走。4號房啊，咁我唔使嘥時間去4號房講兩句啊，好嘛？好。